I'd like to introduce our first speaker, who's my colleague from Queen Mary, Dr. Ruth Dobson, who is well known to many of you. She's a reader in neurology and consultant at Barts Health. She is particularly notable for her recent role in building the pregnancy register, but also in a number of other capacities, working on early detection of the disease, risk factors, and is leading a team around this. Is also very interested in equality, diversity, inclusion topics, and I think it really gels very well with other scientific interests. So she's very well, I think, selected to start off the day with her topic, how pregnant women with MS are treated in the UK. Lessons from the MS Pregnancy Register. Ruth.
So thank you, Klaus, and thank you to all of the organisers for organising me, and particularly thank you actually to David Jones, who has dealt with my dilemma about whether to present or not very, very well. So I was asked to talk about lessons from the UK MS Pregnancy Register. I've slightly shortened the title on my slides simply because it looked very, very wordy when I tried to write it down. These are my disclosures, and also I've been setting up and running the UK MS Pregnancy Register. So when I sat down to sort of write this talk, the first thing I was thinking about is like, surely we've got pregnancy sorted by now. I think over the past few years, I've certainly given a lot of talks about MS and pregnancy, and it feels like actually things have moved on immeasurably over the past 5 years. But we're not there yet. It's such a rapidly changing area, and I think any physician practicing in the MS field is aware that our disease-modifying therapies change so rapidly over time, that our approach to treatment and our understanding of how we approach treatment really changes. And actually there's an awful lot to learn from other areas of medicine as well, for example rheumatology and gastroenterology, particularly with the advent of increasing use of monoclonal antibodies in MS. Because in other therapy areas, in other disease areas, these therapies are much more widely used, and also the frequency of the disease is much higher. So actually there's a huge amount of experience out there. The other aspect to think about MS is actually we're increasingly diagnosing the disease earlier in its course. We've got more access to MRI, our diagnostic criteria have shifted a bit, and we're also starting disease-modifying therapy earlier. So we have a much larger potential pool of people who are exposed to an MS diagnosis during or prior to pregnancy. And I just wanted to start off from this note and thinking about the advent of disease-modifying therapy in MS. And this is a slide that really shows how things have changed over the past 20 to 30 years, with the initial advent of interferon beta, glatiramer coming on just over 20 years ago, and then really an exponential increase in the number of disease-modifying therapies available to us. And as we all know, HSCT is increasingly used or increasingly available, and BTKI inhibitors appear to be just around the corner. But then when we look at actually what's approved for MS and pregnancy, where the EMA approvals sit, it's all very much skewed to the right end of that graph. There's far fewer treatments that have official approvals. And actually the approvals seem to slightly sit on the fence. So when I went into the SMPCs, they state things such as, if clinically needed, may be considered for use, which is quite an anxiety-provoking statement. You know, with interferon, when is it clinically needed? Why may you consider it? You know, ofatumumab could be used during breastfeeding if clinically needed, with no further explanation. And it feels like time goes really slowly. It feels like we get all these disease-modifying therapies, but then there's this huge lag before anything happens in terms of pregnancy and breastfeeding. And actually, as a result of this hesitation, as a result of this slow progress, increasing numbers of women are potentially getting pregnant, deferring disease-modifying therapy, and having MS disease activity, which, as we know, has long-term implications. So in terms of thinking about why does it take so long, I thought I'd just talk through briefly the interferon story and the 20 years it took for interferon beta to actually receive even a sort of fairly faintly worded approval for use during pregnancy. So in 1995, the first interferon beta preparation got its license for use in humans. And actually it wasn't until 1998 really that we were using them outside of clinical trials in the UK. And it wasn't until 2002 that the risk-sharing scheme started, where use became more widespread. This is the same era as PRIMS. So PRIMS was published in 1998. So just to put that in context, this is when we first started to really understand the risks around MS and pregnancy. In 2005, the first pregnancy data on interferon beta was published with 41 patients who were exposed during clinical trials. Now, this is 10 years after this drug actually became available. And it wasn't until 2010 that the first cohort data outside of clinical trial populations became available. And this was 88 patients, a small number of patients. And when you look back at that publication, it says this confirms the safety of this drug. And then in 2011, suddenly you get this large cohort of 425 patients. This is 15 years after this drug comes to market. But then it took another 8 years before the EMA advice was changed, and this was based on national cohort data from Sweden and Finland. And there's a number of reasons for this delay. Part of this is actually what do you use as a comparator cohort? There's sort of various scientific questions. How do you define exposure? But it just really illustrates the fact that this takes a long, long time to get approvals changed. And why does it take so long? Well, it's a balancing act, and treating during pregnancy is a balancing act. And I hope for people who've heard me talk before, I'm not someone who says you've got to treat everyone regardless of their MS, regardless of everything else. Just go ahead and treat them, give them all any drug you want. Actually, no, it's a complicated balancing act. So there's risks of treatment continuation, there's risks to the baby, there's the potential risk of impact of treatment exposure during pregnancy, the potential for teratogenicity. But also, I think increasingly, as we're aware, the long-term potential impacts of exposure during pregnancy. So in MS, particularly on the developing immune system of the fetus, we don't really know what implication that might have during childhood or later in life. And we see this with azathioprine-treated babies. There's also risks around treatment-associated adverse effects, and one that sort of springs to mind is alemtuzumab-associated thyroid dysfunction. If that develops during pregnancy, isn't picked up, isn't monitored properly, then there's a risk of neonatal hypothyroidism. And then risks sort of extending into early life, so risks of vaccination following treatment exposure. And for the mum, there's also risks of continuing treatment during pregnancy. It's not risk-free. There's dual immunosuppression during pregnancy if you're immunosuppressed from pregnancy and immunosuppressed from treatment. That's not something to be sniffed at. And there's the effect on maternal vaccine response as well. This all sits on top of the background treatment-associated risk that as MS physicians we're relatively comfortable with. But then there are also benefits from treatment continuation. It's not all risk. There's the ability to achieve control of MS disease activity, both during pregnancy and particularly in the postpartum period. And it seems increasingly like that postpartum relapse risk is built up during the latter part of pregnancy. So starting treatment immediately postpartum doesn't completely abrogate this risk. And then there's a long-term risk of disability. For the baby, in terms of benefits from treatment continuation, there's the impact on maternal disability, and there's also avoiding the potential need for rescue treatments such as steroids during pregnancy. But this has to be balanced up against risks of treatment discontinuation. So in terms of the baby, risks of treatment discontinuation, again, the impact of maternal disability, and for the mum, relapses, disease rebound for selected disease-modifying therapy, long-term disability. And also we need to be aware that treatment-associated risk, if people have been exposed to treatments prior to pregnancy, this may not completely disappear during pregnancy just because you've stopped a treatment. And particularly thinking about either induction treatments or those treatments with a long lag to effect. But there are benefits of treatment discontinuation. The most obvious is the safety for the baby. And also, discontinuation treatment may not impact on MS control in all people. Not everybody has relapses during pregnancy. It's probably about 10% of women. So it's not that everybody is at the same risk, but we're very bad at determining who is at risk. So I was asked to talk about pregnancy registers particularly. And when I was thinking about this, I thought maybe a good place to start would be actually thinking about how we developed the UKMS pregnancy register and thinking about what can a pregnancy register deliver, why does one start and what can it deliver. So going right back to the beginning. And I think most of the neurologists here will be quite familiar with the UK Epilepsy and Pregnancy Register. This is a register that enrolls pregnant women who have epilepsy. And it's actually really changed our approach to treatment of epilepsy during pregnancy. And it came as a result of significant maternal morbidity and mortality during pregnancy. And I think sometimes as MS physicians we forget that actually epilepsy is one of the leading drivers of maternal mortality and morbidity during pregnancy. And neurologists were facing the same dilemma as we do in MS about, well, what do you do? Do you stop treatment? Do you prevent harm for these babies? And I think the link between harm and treatment-associated harms is much clearer in epilepsy for some of the medications. Or do you continue the treatment and help the mother? And sort of out of this was born the Epilepsy Pregnancy Register to actually look at the safety of drugs in epilepsy. And really there's been this movement, and this isn't just epilepsy, this is across all of maternal medicine, that actually we need to think differently about pregnancy, and we need to change how we think about treatment during pregnancy. Rather than the approach that I think a lot of us maybe were taught at medical school to withdraw treatment, to minimise any potential harm to the baby from treatment exposure, we need to be treating women who become pregnant, who are pregnant, or who are thinking about pregnancy, of being pregnant, the same as a non-pregnant person, unless there is a compelling reason not to do so. And I think this actually makes a really good starting place, that we need to think about, well, why are you doing things differently? Why do you do things differently? And this approach has really driven changes in epilepsy prescribing across the UK. So this is a recent paper from the epilepsy literature showing really that the amount of women who are prescribed teratogenic anti-epileptic drugs have fallen, but conversely those who are prescribed drugs that have been shown to be relatively safe during pregnancy has risen. So women are still being treated. Women are still being treated, they're just being treated with slightly different medications, and this is informed by the evidence. But the other thing that the Epilepsy Register has shown us is really the potential benefit of a register that builds in long-term follow-up. And I remember very well when I was a registrar, there was a lot of focus on congenital malformations, and then suddenly, it wasn't this paper, but an earlier paper came out showing the long-term implications of valproate exposure during pregnancy. That actually, even the babies that did not have congenital malformations were subject to the potential for long-term poor neurocognitive outcomes. And what was interesting is when speaking to the authors of that paper, this reflects what we'd been seeing. We'd been seeing these women come into clinic and say, by the time their child is 10, oh yeah, they're not doing quite so well at school, they're dropping off, they're needing a bit of extra help. And nobody had been able to study this previously, but suddenly you had a register that allowed you to study this, and I think this really changed how we prescribe valproate in the UK. And obviously we now know that there are, the MHRA has the alert forms and things have to be well discussed and documented. So what about MS? What about MS? Can we set something up that really allows us to see that change over time? And have we already started to see changes over time in how we treat MS during pregnancy? And this is data that's come from MS Space, but it really illustrates that in teaching hospital environments and research active environments, we have seen a huge change over the past 10, 15 years in how women who are considering pregnancy are treated. So the orange bars at the bottom are those women who are exposed to DMT at the time of pregnancy. And you can see back in 2005, thinking about the interferon beta story, just when these drugs are starting to become available, nobody is exposed at the time of pregnancy. By 2016, you've got over 60% of women who are pregnant exposed to disease-modifying therapy at the time of pregnancy. Most of this is interferon beta, but this is a huge sea change in the way that we treat this disease, and it hasn't just been the arrival of interferon beta. That's what we see here. It's been a difference in how we think about these things. And we think about these things differently because we know that there is an effect of disease-modifying therapy on long-term outcomes. And I'm not going to dwell on this point too much, but really just to say that this is looking at 15-year outcomes, and in the treated cohort, the risk of EDSS-6, so needing a cane, is far lower. The hazard ratio is 0.3. And within 15 years, only 13% of the treated cohort reach EDSS-6, whereas it's 41% in untreated cohorts. So this is the effect of delaying disease-modifying therapy in order to allow for family planning. It's the risk of having a stick before your child is 18. So back to this weighing up of risks versus benefits. And I think what's really clear across the UK is that not everybody does this the same, and that's fine. We're all physicians, we all work differently. Part of being a doctor, part of being a neurologist, part of being any kind of healthcare professional actually is the art of medicine. And I think a lot of the variation comes from the art of medicine, but maybe there's sometimes too much variation. So this is work that we did a couple of years ago, actually just surveying. We did a completely anonymous survey. I suspect quite a few people in this room took part in this. We managed to reach over 70 MS prescribers across the UK. And as part of this, what we did was we sent out some clinical scenarios, and we said, what would you do in somebody who's on natalizumab, and this was sort of after there was quite well-documented safety information about natalizumab. What would you do? Would you continue it? When would you continue it to? Would you stop it? And as you can see, there really is huge variation. And so about half of people a couple of years ago would stop at 34 weeks. 15% stop as soon as pregnancy is confirmed. 10% stop when people are thinking about conception. This is a huge range. And I think we practice now in this era of social media. And social media can be great, but it can also, bring up new challenges. And one of the huge challenges that it's brought up is Facebook groups where patients will talk about what they're doing around pregnancy. And suddenly these queries start to raise, well, my neurologist told me this, my neurologist told me this. Very different opinions. And people are really struggling to get their heads around this. And this actually causes quite a lot of distress to our patients, where they say, well, I was told it was safe, and you've been told it's really risky and you've got to stop it. What's happening, what's going on? Combined with these sort of regulatory decisions that are slightly sitting on the fence. So back to developing a pregnancy register. So as many of you will know, a few years ago now, we wrote the first set of consensus guidelines on pregnancy and MS. And we put this into the end of the, into the conclusions for anybody that got as far as the conclusions. I don't blame you if you didn't. But we said we want to do a pregnancy register. And in order to write it down and then make you do it, if you write something down and publish it, you kind of have to deliver. And then nothing much happened. And then as part of some other studies, I met this woman who is June Rain, who's now head of the MHRA. She wasn't head then. And the MHRA were extremely aware that they didn't have any information about this, and that actually trials have been lacking, that the evidence is lacking, and really that the regulatory environment doesn't serve women well. And she was like, you have to do this, you have to do this. It's really, really important. And at that point, I was about 34 weeks pregnant. I was thinking, I don't have to do anything. I just have to go on leave. But it's one of those things that never quite goes away. One of those ideas that never quite goes away. And it was like, it does need doing, it really needs doing. And then I sort of got back to work post-maternity leave. It was like, really do need to do this. So, oh, my screen's gone completely blank. Oh, there we go. So what I did is found some like-minded people. And I'm sure many of you will recognise some of the people here. I can't see anyone in the audience who's up in my rogues gallery. But Peter Brex, who many of you will know has been a real star in pregnancy. And then Rod from the UK MS Register, who already had a working register, which is really helpful. And what we actually did is we went to Belfast, and we went and spoke to the people who run the Epilepsy Pregnancy Register to say, how do you make this work? How on earth do you make this work? How do you set it up so that you can get these amazing long-term outcomes where you can really inform practice for people? And so came back from that meeting thinking, yeah, right, we're going to do this. This is really important. We can see why it's important. The epilepsy team have told us why it's important. We know what we're going to do. And then we applied for funding, and of course we didn't get funding. And anybody who works in academia knows that setting up any study is just a testament to repeatedly applying for funding. You never get the funding, or rarely ever get the funding on the first go. And eventually we got the funding and managed to set up the register. So we launched it just over a year ago. We launched it last summer and got a nice graphic. And then I just want to talk a bit about what's happened to date. So to date we've had 109 pregnant people with MS sign up to the register. And of those, we've had 3 people report pregnancy losses. What's been really interesting actually is that we've had people who've reported quite a lot of losses in previous pregnancies. We've definitely seen more previous pregnancy losses than we would expect. This is probably due to who's motivated to sign up to these things. If you've had adverse pregnancy outcomes, if things haven't gone quite how you'd wanted, then you're more likely to think, okay, this is definitely really important. So that's our interpretation of that at the moment. These people are from all across the UK. So, as you can see, we've got some in London, but also all the way up to north of Scotland, Northern Ireland, southwest England. So again, it's a real testament that actually there is a national will to do this. It's not just a single centre. We've seen that actually in terms of age, so this is year of birth, it matches very much UK demographics. So people with MS who are getting pregnant, their median age is around 30. Actually, the median age in the UK is 30. Seeing a slight right skew with slightly older pregnancies. Again, this reflects what we see in the UK population, which is a helpful benchmark to say that people aren't delaying their pregnancies massively. Actually, this is happening sort of at the same age as the healthy UK population. And we're seeing that actually quite a lot of people are registering pretty early in their pregnancy. So most people are registering during the first trimester, although we get some latecomers as well, and we've set it up so that anyone who's at any stage of pregnancy can register. And that's really helpful because one of the things we really don't know is what the background miscarriage rate is. It's quite hard actually to find out what the background miscarriage rate is in the population, let alone in the MS population. So by getting people registering early in their pregnancy, we may be able to shed some light on this. So as I said, we've had 109 people sign up. We've got 106 ongoing pregnancies. We have had some deliveries, but too small a number, unfortunately, to be able to present publicly. Most people have relapsing remitting MS. That's not surprising, given that the mean age is early 30s. And people are getting pregnant, I was quite surprised, relatively soon after their MS diagnosis. So diagnosed at 28 and pregnant at 32. Majority white ethnicity, and we're thinking about what we can do to actually improve the diversity within the register. And this is quite different from the UK MS register population, generally not disabled, EDSS of 2.5, but with higher psychological MS impact scores than physical. And then what we have been doing is asking people actually about what they've discussed about pregnancy. So not everyone's discussing pregnancy in advance with their MS team, actually fewer than you might have hoped, so 85 versus 24. Most are discussing it with their MS neurologist and or their MS nurse. And most around the time of starting DMT or when thinking about pregnancy. And in an ideal world, what we would like to see is we would like to see it coming up, these numbers coming up, so people discussing pregnancy earlier and earlier, rather than at the point of thinking about pregnancy and then having to go through a painful switching process. Reassuringly, most people have taken disease-modifying therapy at some point during their disease course. Of those that haven't, most have been offered. So as a UK, actually, we're doing really well. We're treating people really, really well. We're actually getting people onto treatment. About half and half stop versus continue disease-modifying therapy into pregnancy. And of those that continue, most plan to continue all the way through pregnancy. And we actually looked at the kind of DMTs that people are taking. So those still taking disease-modifying therapy into pregnancy, I was really reassured actually to see that around half are taking highly active disease-modifying therapy and half taking platform DMT, so first-line injectable therapies. We weren't able to split it down any further just because of the small numbers, and we can't report numbers less than 5. And again, of those on highly active therapy, most, about half are planning to continue versus stop, whereas those on platform all are continuing. So I think probably in the UK we are treating far more women during pregnancy than in most other countries. Because when we look at, this is recent data from France, looking at the number of patients who continue disease-modifying therapy during pregnancy, and of those treated, so these are second or third lines, these are highly active disease-modifying therapy treated before pregnancy, by the third trimester, less than 10%, so only 5 out of 70 are continuing their disease-modifying therapy into the third trimester. This is super low. And similarly, even those on interferon and Copaxone preparations, only sort of 20, so about 15% are actually continuing their disease-modifying therapy through pregnancies. This is super low, actually. And I suspect this is what's driving this increase in relapse rate. They've got an intrapartum relapse rate of 1, which is quite high. That's most women having a relapse during pregnancy. But more importantly about pregnancy registers, it's actually got people talking about this. And I think, thinking 10 years ago, we just didn't have talks at conferences like this about MS and pregnancy. And now they're at every conference, which is brilliant. And I think, raising awareness of this, our patients are far more aware than they were 10 years ago. They talk about this. They talk about this a lot. And then they come and tell me what they've talked about. And so, this is something that is really happening. And I think as neurologists, actually, we may be slightly behind the curve of our patients. There are still unanswered questions. And I think or unanswered issues. And I think one of those actually is with HSCT, because the HSCT is going to be a very powerful treatment as it comes online. But for women who are thinking about pregnancy, it's about 3 months to starting treatment by the time, if they're thinking about pregnancy in the future, if they've gone through egg retrieval. So if you have somebody that's even vaguely considering HSCT, actually this is something that you need to think about really, really promptly, because it is not an easy process, it is not a quick process, it is something that takes time to set up and to do well, and it's really important. There are documented pregnancies that have occurred spontaneously post-HSCT, but you certainly can't rely on that. HSCT does impact on fertility. So I think that's a really important aspect that probably we're not thinking about early enough in the treatment pathway at the moment. I think the other thing that we are still coming to grips with is actually this issue about withdrawal of immunosequestering treatment, particularly natalizumab, fingolimod. It remains unclear, but likely that the other S1Ps will have the same effect around disease reactivation. And also therapeutic lags on treatment reinitiation postpartum. Does starting treatment sort of after childbirth, does that prevent that postpartum rebound? And you'd think that would make sense, but we don't really know that yet. And this is just some German data about the impact of withdrawal of natalizumab during treatment. So in this study, in those women who had natalizumab withdrawn during treatment, they had severe disability in up to 20% from relapses, sort of up to the level of requiring a cane. So these relapses are bad relapses, and they set people up with disability for life, sadly. And I think this brings us back to the fact, and Klaus sort of slightly touched on this when he introduced me, is that exclusion criteria matter. And we see this in our trials, and we see this repeatedly, and we've seen it during COVID. We've seen it particularly dramatically during COVID, where pregnant women were excluded from vaccination trials. As a result, pregnant women did not take up COVID vaccination, and last autumn and winter we had ITUs that had pregnant women in them because they had not been vaccinated, and actually all of the pregnant women admitted to ITU with COVID had not been fully vaccinated. So these exclusion criteria matter, and they change how people think about disease-modifying therapies. They change how people consider these treatments. And, I think we do need to think quite carefully about who we put into trials and how we look at our trials as well. So when looking at randomized control trials, actually we don't disaggregate by gender. We don't disaggregate by age. We put on these very artificial cutoffs, and quite often we put these cutoffs on because somebody else has done it before, so it's perceived to be the accepted thing. Like in a particular issue of classes is the upper age cutoff, and actually putting an upper age cutoff. There's no rationale for this in a lot of trials. Why do we exclude people with lots of comorbidities? And similarly, why do we exclude people from trials who might be thinking about pregnancy in 5 years' time? That's a long time away. So what are the missing pieces of the jigsaw? I think we're getting there with pregnancy. I think we really are in a very different place than where we were 5 years ago. But we still need more information about IVF. There's a recent paper that's just come out in Neurology with a very large case series of IVF. It's taken from population-based data. There was sort of not that granular details around MS or about the IVF treatments, but it's increasingly looking like IVF doesn't actually impact on relapse rate to the extent thought previously, particularly in those cycles where there's successful pregnancy, and even more importantly, particularly in those cycles where treatment is continued during IVF procedures. So where disease-modifying therapy appeared to be given sort of during or covering IVF, then actually there was no discernible increase in relapse rate. We also don't understand much about miscarriage in MS. We think that miscarriage probably increases the relapse rate, but actually that data is quite hard to look at. And we don't, there's a lot about early miscarriage that we don't understand. And finally, the role of induction therapies and how to use induction therapies around pregnancy. And I think as we increasingly use induction therapies, and increasingly use, for example, anti-CD20s where we can potentially space out the dosing interval, how do we use that around pregnancy? Because really the holy grail is to get a pregnancy that's not exposed to disease-modifying therapy, but also has good control of MS. And I think induction therapies offer us a window into how we might be able to do this, but we need to understand the best and the most effective way to do that. So in conclusion, we need to do these trials. We need to do trials that represent the real world, but we also need to collect real world data alongside this. And pregnancy registers are a way to do this. It's not that we should be including pregnant women in clinical trials, although we do currently have a trial running looking at ocrelizumab exposure during pregnancy. But we need to be thinking about actually how can we do these trials that really answer these important questions. We should be considering possibility of pregnancy in all women with MS of childbearing age. I think our data shows that this doesn't always happen in a very planned way, and it's not always discussed, and it's actually on us as physicians to think about this. But we shouldn't be denying women high efficacy therapy when it's indicated. And working around pregnancy is really cool. It's the epitome of personalised care. You actually get to discuss these things in detail and really drill down into risk benefit and how people feel about pregnancy. It's just that none of us really have time to do that, but it is an opportunity. And finally, my plug is don't forget to encourage patients to sign up to the pregnancy register. They can do so if they have MS and they're pregnant. That's all that's needed. So I'd like to thank you for listening. And I'd like to thank particularly the MS register who sent me all the data on Friday evening that I presented.